turn it over to you, Dr. Bose, to introduce yourself.
Okay, great. Well, thanks for the invitation. Happy to be here. Very excited to, of course, now be here at the University of South Carolina as a new assistant professor in environmental health sciences. So my name is Devin Bose, and I'm going to talk today about how we can use wastewater to generate population level health assessments and how we can make them inclusive and how they are non-invasive. So first I'm going to put you all to work, and those of us who are here, you have a note card in front of you or near you, and I'm just going to give 1 minute for you all to jot down what are all the things that you have interacted with so far today. By an interaction, I mean an encounter, an exposure. For example, I took a shower this morning and I used shampoo. That would be my exposure. So think of, we're midway through the day, think of all the things that we've interacted with today. And for my friends online, grab anything around you where you could probably jot something down and do the same. So I'm going to give us 1 minute. Name all the things that you've interacted with so far today. So I took a shower, I interacted with shampoo, the water, etc.
People also, or just inanimate?
That can include people as well. And it doesn't have to be very specific. You could just say people. All right, maybe just about another 30 seconds. All right, very good. And you're welcome to just put those off to the side. We will get to them later, I promise. And it will make sense, hopefully, by the end of today's presentation. All right, so this works. I think it's very important to kind of go through my journey just briefly, especially when I know I have students in the room, to just let everyone know that it doesn't always have to be a linear projection to maybe get to where you want to be or to get into the position that I'm in. So I did start off, I got my undergraduate degree in my Bachelor's of Nutrition and Dietetics at Westchester University of Pennsylvania, but I actually started off as a health and PE major. So I played Division II women's lacrosse at WCU, and prior to that, I was always an athlete. I was a coach throughout high school for youth sports. Being in that role of a coach and helping people through movement just always felt like a logical or just a natural progression for me. As part of this program, I was only required to take one course in nutrition, and it was a very basic Nutrition 101 course, and I immediately fell in love with the nutritional sciences, and it was almost a little bit, I don't want to say shameful, it feels like a very powerful word, but I never had to think about the things that we eat and how it actually contributed to our health. Growing up as an athlete, I just would come home, I was hungry, needed to eat, wanted to move on, but never really thought about all the different components of how nutrition impacts our health. So I ended up switching, and it did tack on a 5th year for my undergraduate career, which I just called my victory lap. I do not see that as a bad thing, and would not change that decision for the world. I then later moved out to Phoenix, Arizona, and I earned my PhD in what's called biological design, which you can consider, sorry, I'm just trying to get this off the screen, an interdisciplinary or an applied engineering type of degree. Prior to that, I was working as a nutritional counselor at WIC. So this is a women, infants, and children's clinic. So I would distribute WIC checks. I would provide education and support when needed, but more so when I had the time. So I was only provided about 10 to 15 minutes to work with each participant. As you can imagine, to perform a full nutritional assessment and education, that can get a little tricky. So kind of due to that experience, I went off and started more so of a blog that I called Nutrication Wellness, so combining nutrition and education. And here I just wanted to transfer that knowledge of nutrition to the world, to my friends, colleagues, family members, basically anyone who would be willing to work with me or listen to what I had to say. And from all of this, I decided to apply to a master's in nutrition finally at Arizona State University. I was accepted early in the spring. And by what I can only call a serendipitous moment, I met an individual. And I actually was working multiple jobs at the time, part-time at an Apple store. I was a technician, and this person ended up being my customer. He was a professor in environmental engineering at ASU. And we got to talking, and at the end of the conversation, he said, "Why don't you come by and just come check out my lab?" And I said, "I don't know what I would be doing in an environmental engineering lab," but there was something that drew me, and he started talking about wastewater-based epidemiology. He just kept saying it and kept saying, "Oh, you could use this to analyze the nutritional status of populations." And I thought, I don't know, I'm not sure about this guy, but I'm intrigued. So I did. I ended up visiting his group meeting and still felt like I was a square peg in a round hole, but something was drawing me to continue. And I ended up switching yet again from my master's in nutrition to a PhD in biological design, which is ultimately what I ended up getting my degree in. So from that experience, I then moved on as a postdoc to Boston University, where we looked at all of the ways that migration can impact human health, which is what I was working on as I left and still continue on today. So definitely not linear. Trust your gut. You never know who you're going to meet, and happy to chat more about that. So ultimately, what motivates me today is I'm just dedicated to making sure that everyone has the information that they need to be able to make the right decision for them. And this, of course, saw a lot during my work as a nutritional counselor. So at least here in the United States, it can be very confusing. People are oftentimes faced with the very daunting task of reading a nutrition label, trying to understand what all of that means, percent daily value, reading and understanding what the ingredients are. And then on top of that, we have TikTok, Instagram, everything on social media telling us what we should or should not be eating, what's the latest diet fad. So this can lead to a lot of confusion and overall frustration that can lead to some different behaviors that may or may not impact our health. And overall, the way I see it is by proper instruction and support, we can then sort of mitigate some of that. So ultimately, what I'm getting at is in public health research, overall, we are doing a lot to understand the basis of the problem, but we might not have all the pieces to the puzzle that we need in order to get ahead of it. And all the while, we're left with gaps in knowledge. And within those gaps, we know that there are select populations who are greatly impacted and disproportionately impacted by, again, by these gaps in our information. 6 out of 10 Americans are currently suffering from at least one chronic disease. 4 out of 10 have at least 2. So there must be something else that we can use to complement these data sources in order to, again, really operate at a pace that's comparable to disease incidence. And this is where I really feel that wastewater can fill in those gaps to overall promote a precision public health model. We have precision nutrition and medicine. Why not use this to tackle some of our biggest public health problems that we see today? So first, what is wastewater-based epidemiology? And from here on out, I'm going to say WBE because, as you can imagine, it can be quite a mouthful. And I do want to acknowledge that kind of depending on who you talk to, we tend to have multiple terms to ultimately refer to the same concept or methodology. So wastewater-based surveillance, sewage epidemiology, so on and so forth. And depending on who you talk to, again, these words might mean different things so epidemiology will have it has a very defined definition, of course, in relation to or compared to surveillance or monitoring or testing. But at the end of the day, again, the concept is going to all be the same. All right, so you are welcome. I invite you to close your eyes if you wish, if it will help. But imagine the last time that you maybe visited a doctor. Perhaps you weren't feeling so well, or perhaps you were just there for an annual checkup. And as soon as you get there, what is the first thing the doctor asks? What brings you in today? And then you might start to do some self-reporting. Well, I've been having headaches, or I just haven't generally been feeling so well. So you're reporting some symptoms. And then generally at the end of that appointment, the doctor will likely request some type of blood, urine, or stool sample. Once those results are obtained, the doctor will typically look at those two data sets in tandem, the reported symptoms and those quantitative biomarker results, to see whether or not we can diagnose or rule out a problem. Now think about that in relation to a population. So we have an entire community, this might be shocking, but we all use the restroom. And so ultimately this, what WBE does is it leverages the fact that we all have our business, and anything that runs down the drain, the toilet, a sink, shower, even the laundry, that will ultimately make its way typically to a wastewater treatment plant. We're talking about in more sophisticated sewage infrastructure systems that we see typically here in the United States today. Well, what I like to do is capture that very yummy untreated sewage that is on its way to the treatment plant or within the sewer infrastructure there, because it contains those same biomarkers, chemical and biological signatures or agents that are indicative of various aspects of our lives, things that we consume, medications we use, or what we're exposed to throughout the day. And ultimately what this is doing is creating a population level health assessment. Now, given the composited nature of a wastewater sample, there are some unique benefits to doing this. So it is considered to be anonymous. Not one person can be differentiated from the next. It's non-invasive, so everyone can live their lives as they naturally or organically would. Don't have to call a sitter, leave work or school. Everyone just gets to continue living, all the while we can collect that information in the form of that sample. It is inclusive, so there are no inclusion or exclusion criteria in terms of population groups that we would recruit or not recruit as part of the study that you are undertaking. And it's considered to be in near real time. So typically, and compared to at least other data sets where maybe they're released every couple of months or a year, typically we're looking at a couple of days or weeks. We can turn around those data depending on the application and personnel and infrastructure of the lab. Really want that top thing to go away. So now that I've given you all a crash course, we're all experts in WBE, let's talk about some case studies. So from here on out, I'm going to really dive into two major case studies that demonstrate how we can use WBE for true public health action and strategy. And then later talk about just two more, and then go on and talk about what I see myself doing in the future here at USC. All right, so just as I was starting out in my PhD back in 2018, I was put onto a very major project in partnership with the city of Tempe. Now, the city of Tempe is where ASU is housed. And the overall goal in this partnership was to reduce overdose events and substance use. Really, the city was very motivated to eradicate substance use altogether throughout the city. And of course, this was in response to the opioid epidemic. So we saw basically since the late 1990s, we've been seeing several waves of opioid use, almost peaks as time has grown on. And at the time this study or this partnership came to be, was right about the third wave with the introduction of more fentanyl. So this is back prior to the pandemic, and honestly, people really didn't know what this type of work was. So we really had to engage with the community, let them know what we intended on doing, and more importantly, why and what we intended to use the data for. So we held town halls, various webinars, and ultimately we were met with a lot of positive feedback. People were, for the most part, very happy and gracious to us to even want to pursue this type of application. So that allowed us to get right down to it. So we started sample collection and analysis very shortly after. So something unique about Tempe is it doesn't have its own wastewater treatment plant. It actually shares with 5 other cities within the Phoenix metropolitan area, and they all feed into a single very large wastewater treatment plant in Phoenix. So what they have to do is monthly compliance monitoring to make sure that their effluent from the city of Tempe is remaining within regulations when Phoenix is receiving their sewage. So they do this every month for 7 consecutive days, typically on a Monday through Sunday schedule. So we would go out and basically just follow them around with coolers and collect samples or splits of samples that they were already taking. And this made for a very kind of fluid way to just locally collect samples. And so given that opioids are chemicals, we analyzed them using what's called liquid chromatography, tandem mass spectrometry, and incorporated other metrics, including population estimates and flow measurements in order to ultimately reach a mass per capita per day type of result. So this is a direct outcome of this partnership. So what you're looking at is from Wastewater Informed Online, so an open access dashboard for opioid use at neighborhood level or sub-sewershed level throughout the city of Tempe. And so the catchment map, so each wastewater catchment is a different color. And you can just picture it as, so there's a single access point that we would collect sewage from within each of those areas. And you can just imagine that it captures all the sewage within that colored area. And that was all predetermined by the city just based on the pipe network. Now, the 4 panels along the outside, along the perimeter of the screenshot here, they're indicating 4 major opioids that we were targeting: fentanyl, oxycodone, heroin, and codeine. And the italicized words are the major metabolites. So we weren't just measuring what's potentially being dumped down the toilet, we were also measuring consumption, what was being metabolized. And so each month we would, again, collect that 7 consecutive day cycle, analyze the data, and then meet with the city of Tempe and other stakeholders to talk about what has changed from the previous month and what do we need to do in the months to come. So mostly what we looked at in tandem here were the wastewater data as well as what's called the opioid abuse probable EMS call dashboard. So these were the calls in the event of a potential overdose throughout the city. And what fire and medical rescue would do is they would utilize this information and say we had an uptick in that large area, that blue area there, so area 1. They would say, okay, maybe we need to be better equipped with naloxone or Narcan, which is the antidote for an opioid overdose in those areas so that we can better respond and reduce that death to overdose event. Also, at that literal round table that we would sit out each month would be individuals from crisis response and interventions teams and city engineers and water utilities. So very interactive and integrated partnership here that did turn out to be quite fruitful in ultimately serving to mitigate substance use throughout the city. All right, so the dashboard we created, officially we started to monitor in May of 2018, and then it was officially launched in February of 2019. Who can tell me what happened maybe about a year later? You can shout it, it's okay. Yeah, thank you. We had COVID-19, our good friend. So not to take this lightly, this was absolutely a very, as we all know and live and continue to live through it, we were met with a great deal of uncertainty, fear, resource depletion, burnout. So we said, hey, this is a great opportunity to leverage this current infrastructure for opioid monitoring to very quickly switch to monitoring for COVID-19. So to put this in perspective, we actually had one of the first cases of COVID-19. An ASU student was recently traveling. January of 2020 came back and was COVID positive. So that sparked a lot of conversations, of course, within our team with the city of Tempe. It said, hey, I think that we have an opportunity to respond to this here. And just a couple of weeks later, we flipped an analytical chemistry lab at Medical for Mass Spec to be able to analyze for COVID-19 using qPCR. And starting early April 2020, we were ready to go. So we started collecting throughout, again, that's our friendly catchment map. We've added a few more catchments here, and that was just to enhance our spatial granularity there, and also increased the number of samples that we collected. So instead of 7 days per month, 3 times per week, from April 2020 through March 2021. And this is still going on today. So this is very much just a very tiny sample set now. So a little over 1,500 samples went into this particular study. And again, we were targeting SARS-CoV-2. So this will look very familiar to the opioid dashboard. So we have our catchment map, and this is about a month's worth of SARS-CoV-2 data. Instead of showing it as a mass per day, we're showing it in genome copies of SARS-CoV-2 per liter of wastewater. So this is a concentration. And so as you can see, again, each bar on the graph, the color corresponds to the area on the map. So citywide monitoring of SARS-CoV-2. And this dashboard was officially launched early in May of 2020. So now let's expand. So we have that full data set here, April 2020 through March 2021. And as you can see, it's quite a bit of data to just, kind of shove into a small screenshot here. But you may be able to tell that we have three major waves of infection here. So this initial one is right about, so in Arizona, the governor lifted May 15th, the official lockdowns. Took a little bit of time, restaurants were still kind of easing their way in. And then just about mid-June, we started to see that spike come up there. So that's that first wave, the initial after the official lockdown was released. And then wave 2 was actually kind of unique. We weren't seeing this anywhere else on any of the other data sets or dashboards that were being posted at the time. And so we looked at the dates, and it was just about late August, and we said, oh, this must be ASU students coming back. And it's very difficult to tell on the screen here, but if you were to kind of put your face up to the screen there, the colors will correspond to the catchment areas towards the top of the city there, the northern end of the city, and that is where ASU is housed. And then, of course, we have our third wave as we get to the end of 2020 into early 2021. All right, so another interesting aspect of this was we were also collecting from within what's called the town of Guadalupe in Arizona. And this is actually a separate municipality from the city of Tempe, but they worked very closely with us. They were very motivated to work with us here. So this is a town of about 6,500 residents, typically multifamily homes. A large proportion of them are of the Pascuayaqui tribe in Arizona. And immediately, so I'm going to show that initial map that I just showed you in the previous slide, where we have all of the catchments here, except this one excludes the town of Guadalupe. It's on its own tab on the dashboard. So if we look at it here, during that kind of initial ramp-up period after the lockdown or during the lockdown, and then when it was released, we saw very high levels of SARS-CoV-2 in the town of Guadalupe. And you can't see the number there, but in the millions here. And we were very shocked by this, of course, and we felt that we wanted to relay this information right away, which is what we did. We mentioned to the city of Tempe, who then relayed that to the town of Guadalupe leaders. And they were the ones who integrated, based on these data, targeted interventions, so mask mandates, a little bit more of educational strategies to raise awareness, and generally just making individualized testing more available in select areas throughout this town of Guadalupe. So with those efforts, we did see concentration levels decrease later on. And this did catch quite a bit of attention in terms of just how we can use wastewater as a way to rapidly deploy an intervention. My favorite was they called us sewage sleuths, which I thought was t-shirt worthy. But very, very much, it felt really great to feel like we were really part of something, really contributing to public health. So what about an early warning potential? And so we talked about rapid interventions, and we saw that unique wave with ASU students coming back into town. So we wanted to test if wastewater was able to actually herald a signal of infection compared to typical clinical surveillance. So what you're looking at here is the same exact data set, except just shown in a different way. And now we're looking at genome copies per day. So this is a viral load of SARS-CoV-2. And we're looking in aggregate the city of Tempe. And so again, the blue is going to be that wastewater measurement. And then on the right-hand side, the pink are cases per day. And the cases are the newly detected clinical cases per day reported by the city of Tempe, and by zip code broken down. So zip codes 1 through 4 go from north to south. And again, zip code 1, that's in the northern end, we see that unique second wave, which we don't see in any of the others. So again, we wanted to test if wastewater was providing an early warning signal for SARS-CoV-2 in the area. And we tested this by doing a root mean square error statistical test. And we did see that almost up to 2 weeks, at least in the very early stages of the pandemic, we saw an early warning of wastewater being able to serve as that leading indicator. And as the year grew on, it actually turned into a lagging indicator, as you can see by the negative numbers there of -2, -4. And so we looked more into this to see reports of clinical ramp up and capacity. And it actually took nearly more than 6 months for clinical testing to operate at a comparable pace to wastewater-based epidemiology. So what does that mean? 6 months is quite a long time. And had this potentially already been set in place, rather than, we're just sort of testing everything out, maybe we could have mitigated some of those case rates, hospitalizations, and deaths. So an opportunity for the next pandemic, I suppose. All of this that I just described is summarized in a paper that came out earlier this year, talking about opioid monitoring and how we use that to leverage a very rapid switch to COVID-19 monitoring. Alrighty. So 2 very, real world examples of how we can use WBE to really complement and support public health strategies. What else can we do? The short answer to this is a lot. And we're still figuring this out of all the, the limitations, what we can and cannot do. I'm going to show just 2 more brief examples and then talk about next steps. So of course, something that's very near and dear to my heart is nutrition. So again, 6 in 10 Americans are suffering from at least one chronic disease. Typically, these are nutrition-related or lifestyle-related chronic diseases. So not only is this causing a lot of mental, physical, emotional burden, it's also greatly impacting our wallets. Significant financial burden and healthcare costs for diabetes, heart disease, and cancer, all of which are proven to be nutrition-related. So knowing that a plant-based diet can bring us some significant health benefits, so this is just eating more plants than animal-based products or meat, I decided to experimentally test out whether or not we'd be able to assess a plant-based diet from wastewater, so getting that community level perspective. So I use phytoestrogens as a proxy for this. Phytoestrogens are plant chemicals. A subclass are isoflavones and also lignans, so 2 subclasses. And then the chemicals genistein and daidzein will reflect our isoflavone consumption. Typically, we consume these through soy-based foods, so soy milk or tofu, tempeh, etc. And then lignans are much more ubiquitous. So beans, fruits, berries, nuts, seeds, we're going to eat lignans through all of those sources. And I chose the chemical enterolactone to be able to assess lignan consumption. And generally from the literature, we can gather that Americans consume approximately 1 to 3 milligrams per day. So every day we are all interacting with or consuming phytoestrogens. So if I could draw your attention just all the way to the left. So again, our friendly catchment map, but I have a circle around teeny tiny purple area there, area 6. So this is roughly a maximum population of about 10,000 people. Isolated residential community. It does not receive any infiltration of sewage flow from other neighboring catchments, so it is its own unique signal. And that is one of the major reasons why I chose this to test this out. I figured it would decrease uncertainty here. And so what we're looking at, so this is a 2-year study. And I'm sorry, I'm still trying to get this to go away, but it ran from August 2017 through July of 2019. And what you're looking at is total phytoestrogen consumption in milligrams per day, per capita, or per person. Each yellow dot is the sum of those 3 chemicals, genistein, daidzein, and enterolactone. That gray shaded region, which actually looks pretty faint up on the screen here, is that US estimate 1 to 3 milligrams per day. And the dashed line is the average that I measured in wastewater here. So I looked at this and looked at my colleagues who helped me on this study, an undergraduate and research scientist, and we looked at each other and we thought, what's happening here? We see this huge increase from December to January that lingered a little bit through February and March, and then very kind of quickly tapered off for the rest of this first year, August through July. What is something that people say that they're going to eat at the beginning of each new year? What do people say they're going to eat more of?
Plants.
More plants. I'm going to eat healthier. So, of course, without distributing surveys or interviews or really getting connected to the community here, there wasn't a way to really confirm this for sure. But we thought, are we actually measuring a behavior change at the start of the new year? Is this New Year's resolutions? What I did was I just wanted to repeat this for a second year. So I did, and we saw that same exact trend, except a little bit more dramatic from January into February here. So what essentially we concluded here is the trends seem to be similar between years, which is giving us an indication that we could very well be collecting information that is a behavior change. Again, think back, it's a very small community. It is isolated, very minimal transient populations going in and out. It's highly residential, not receiving any sewage from a neighboring catchment. So it's very possible that we could be capturing a behavior change here. Again, without those more contextual community-based methods, we cannot confirm. This is a little bit anecdotal, but seems pretty strong according to the data up here on the screen. And again, we did a lot more to add into the complexities of what it might mean to understand nutritional behavior from such a population level perspective. And all of this is summarized in another paper that came out earlier this year. All right, so moving on to the work of my postdoc. So moving on to global health applications and seeing how we can integrate this work into migrant populations. So just recently had a paper come out where we talked about considerations for what we might need to be thinking about in conducting a wastewater-based health assessment in such a sensitive population. And to give you some just brief background, there are, as of 2020, about 280 million migrants globally. Given the conditions that they're in, they're very susceptible to poor living conditions and diminished access to resources. Essentially, the World Health Organization has deemed just simply being a migrant puts you, it marks as a social determinant of health, puts you at risk for a multitude of diseases and conditions. So I see this as a great opportunity. We have a lot of information about health of migrants at their destination regions, very little from their place of origin, essentially no information while they're en route, while they're traveling along a migratory pathway. They do check into what are called reception centers along the way. There are various camps, of course, but they are oftentimes operating at a capacity, and these conditions are very much, again, they may have a roof over their head, but they still are exposed to a number of things. They do not have a lot of access to care. So earlier this year, I found myself walking around the rural areas of Bosnia, which was, amazing, but also I was laughing to myself, like, where am I? Just walking around this area here, right next to a reception center, nearby to a camp, looking for manholes. Walking around with the water utilities there and just popping them wherever we saw them. They had plans that we could tell where the sewage was potentially coming from to determine if we can capture an isolated signal from the community. So we did, as you can see, identify a couple. And this is one of those projects that we're still, it takes a very long time to ramp it up. We're working with the International Organization of Migration. And everyone seems to be quite on board to, or having open arms to this. Hopefully I have more to report in the future. All right, so now what's next? But first, let's name some of the interactions that we all wrote down earlier today. I'm going to, if we're feeling maybe a little shy, we don't want to just shout them out. You're welcome for the next, yes?
We have to online. We can just
Okay, perfect. Thank you, Katya. So for the folks in here, how about let's just chat amongst ourselves, maybe turn to your neighbor, talk about what you wrote down for just about 30 seconds, and then we can break it out to the greater group, and then we can tackle the ones online as well. So 30 seconds to a minute. Interesting, interesting. Okay, amazing. Thank you, everyone. I appreciate your participation. So was there anything that maybe was common or similar with your partner? And you're welcome to shout it out.
Coffee.
Coffee, okay. That's important. Anything else?
Water.
Water, yeah. Mm-hmm. I see online, I see a lot of brushing teeth and toothbrush. That seems to be similar. Yep, coffee. Anyone have breakfast today? Did we have any mid-morning snacks? No, Sean, no snacks for you? All right. Yeah, Katya?
Door handles. Door handles came up a lot.
Door handles, that's great. Yep, that's a really good one. Mm-hmm.
Computers.
Yep, computers. So our computer keyboards, when's the last time you think we wash those, or how often, right? Yep, elevator buttons. Yep, so this is great. Great, thank you, everyone. So all of these things that we've interacted with, touched, potentially consumed, inhaled, we're referring to here. Ooh, if it wants. Oh, wait, where'd it go? Oh, shoot. Thank you. Okay, so everything that we just talked about, oh no, now it doesn't want to progress. There we go, is referring to the exposome. So the exposome refers to the exposures that an individual encounters throughout their life course, so pre-birth through death, and how these exposures impact health. And what I'd like to do is progress the field of WBE. We have already been doing this, but in a more formal structure, using this to assess community level exposome. So as you can see in the definition there, it focuses on what the individual encounters, and traditionally the exposome has focused on that, the individual. And again, similar to the individual methods for nutritional assessment or clinical surveillance taking 6 months to reach a capacity, we just might not be operating at a scale that we need in order to get ahead of some of these issues. This is what I am pursuing moving forward. I have identified around the graphic here areas of focus that I am either currently working on or would like to work on. But more so, it's not just measuring these in wastewater, it's what are we doing with that information? So I very much am looking through all of this through the lens of social determinants of health, climate injustice, health equity, and how all of this relates to relations to chronic disease incidents, neurodegenerative diseases, mental health, dysbiosis of the gut. All of this we are learning more and more is very, very intricately connected, and we can use wastewater to demonstrate these connections, fill in those knowledge gaps. So hopefully by the end of today's presentation, it seems clear that we can certainly use wastewater to be integrated into the public health infrastructure and understand the health of populations, the things that we are exposed to, our interactions with our surrounding environments. The sewage doesn't lie. It's a very quantitative, objective type of measurement, again, at community scale. There's much more work to be done, and this is where I need some help. So I am recruiting and I'm open to collaborating. If you want to play with wastewater, please feel free to reach out to me. I'd love to chat with you. If you find yourself feeling like we could collaborate on a potential project, please feel free to reach out and join the Asher Lab. And without further ado, I do want to take a moment to just acknowledge all of the people, individuals, centers who I've had the pleasure of being part of. At ASU, Center for Environmental Health Engineering and the Center for Health Through Microbiomes, led by Drs. Rolf Halden at EHE and Rosa Krishmalnik-Brown at HTM. And then the Center on Forced Displacement at Boston University, led by Dr. Mohammed Zaman. Of course, the city of Tempe, most of what I showed you today would not have been possible without their just overwhelming support. And of course, my funding sources. And I will leave it at that. I very much look forward to a discussion and your questions. Thank you.
What?
Yes.
Yeah, I think that your overall presentation was great. But I specifically thought it was interesting the plant biomarkers that you looked at for chronic disease. Have you thought about or seen where people have used biomarkers that are specifically target for like people exercising?
You know what? I want to say, so not that I'm aware of, at least reported in the literature, but this was brought up a long time ago at ASU in conversations with folks at the Student Health Center. They were very interested in seeing, potentially working with us and seeing if we could be able to tell, an increase in exercise or not, or beneficial impacts of exercise. And you can probably, like with many, when we're talking about these endogenous type of biomarkers, gets a little bit complicated because we run into an issue of specificity, right? So, for example, we can use the biomarker cortisol to understand stress levels in a population, and we have been able to do that. But cortisol is also elevated when we go out for a run. So that's what I'm talking about in terms of specificity and trying to understand impacts of these lifestyle behavior changes that could either help or hurt our health. So it's a very good question. I'm definitely interested in exploring that. Yeah.
I had a question. Actually, wastewater treatment was like one of my first interests as an undergrad.
Okay.
I think my hometown had a representation came by to do a talk.
Cool.
And I was, I even asked for a tour. They gave me a tour. I was very shocked because I was familiar that all they did was deal with wastewater.
Yeah.
But I was very shocked. They showed me their organic chemistry lab, their microbiology lab, their molecular biology lab. I was very shocked how invested they were into the research too. At that time, they were working on a project turning wastewater into drinking water. One of the things that I was curious about though was it seems as though wastewater treatment is becoming more clinical. In regards to they aren't just treating water, they're actually trying to prevent disease.
Yeah.
Because they had the sanitization had their own parasitology department. One thing that not a lot of people knew because they're private.
Sure.
Is that the case that we're seeing with wastewater treatment that is becoming more than just providing a resource that is becoming more of a clinical practice?
Yeah, I mean, clinical, So I totally know what you're talking about in terms, like, it definitely seems because of the pandemic and due to all of the success with COVID-19 monitoring using wastewater, people are seeing wastewater treatment plants a lot differently now. It used to be, oftentimes, at least personally for me, before I started this work, did I think about what happened to my waste after I flushed the toilet? Now I kind of do, which might be weird, but I think a lot of people are more aware of that in terms of where that goes and what that could be telling us. And so I think people are viewing treatment plants now as more of these like public health entities, which many of them, as you've described, very much have become. They're very well set up for various testing. So I hope that we see more support in that area to support our utilities, seeing it less as just, something that they have to do and more of that they are actual stewards of public health. Yeah, great question. Thank you.
With the plant based diet, I found it interesting that you mentioned isoflavones because there's a lot of soy allergies and people are various sorts that think that it increases the risk of disease or anything. So you consider you've been testing other besides the lignans, testing other categories of flavonoids or?
Yes, definitely. Even beyond just, the umbrella of phytoestrogens. I have currently working on, a grant proposal where I want to expand that biomarker suite to, not just plant-based broad, but maybe cruciferous vegetables, whole wheat and grains, meat-based sources, things of that nature, so that we can really actually get a full assessment. Yeah, we can also expand to polyphenols as well. Definitely.
Follow-up question.
Sure.
One of the things I didn't really notice in your presentation was any linkages between demographics. Either a minority or misrepresented community, or the age of the community. Is that something that you're working on as well?
Definitely.
Okay.
Basically speaking to what I had up on the slide here. So making the connections to socioeconomic status, other indicators, metrics of demographics, and differences between population groups, and how that relates to disease incidence and also the exposures too, right? Linking them all together.
One of the things that I found most interesting is how uninformed my community was about how their water is treated. They weren't aware that most of the water is being treated by a private company.
Gotcha.
They assumed that it was the city handled it, and the city to some degree handles it, but
sure,
the city contracts it out.
Yeah.
Of course, other communities with the resources have that information, but not the minority community.
Right. Yeah, it's very important to raise that awareness for sure. Yeah, great question. Thanks.
So let me take the Marcus's question down a different avenue, going back to the work that you all did with the opioid monitoring, and the intent was to kind of identify hotspots and help to address the issue. So I talked about my little place in West Virginia, and it is situated near what's considered the opioid abuse center of West Virginia. We have the opioid abuse area here in South Carolina and North Carolina that parallels the corridor of educational shame. And a lot of work we do with underserved communities, and wondering, has there been efforts to use opioid monitoring from a different angle, using it to identify where there may be criminal activities taking place? And if so, is there any pushback from these communities? I was thinking about here in Rosemount and doing work like this, but we know that there are some issues in Rosemount and the other Lampsey communities that the communities may feel like they are being picked on.
Yeah, I would say it's a very delicate subject in the field, because people don't, generally speaking, I think people don't want to feel like they're being surveilled to invoke some type of retaliation by law enforcement, right? So we want to be very careful about kind of dipping into that area. There are wastewater-based epidemiology programs that exist that are working directly with law enforcement. I know of one particularly in China, and they are using it as a direct way to find hotspots to make arrests. I think, so it is something that is happening.
It's kind of like finding that fine line between surveillance and public health. It seems like you're more concerned about the public health aspect, getting the people
right
they need, as opposed to observing their activities through what's coming out of their home.
Yeah, I mean, I think it's a personal choice, maybe, or overlapping personal and professional choice. I'm always just more concerned about the public health implications, and how, like, to me, if we can get to the root of the problem, the why people are using, then we hopefully will see decreased, essential criminal activity, I guess, for a lack of a better term. So I want to focus there. But I do know that people feel very strongly about focusing on the other end. And, that's just I don't want to call it a difference of opinion, but I just don't want to get into that area of law enforcement. Yeah, I think Sean also had a question when Dwayne, so I'll get to you, Laura, thanks.
So one is to follow up on what we were just talking about.
Yeah.
So yes, early on in the surveillance, what we were doing, I'll say that we moved away from the word surveillance as soon as Homeland Security in the beginning stages of all this. Homeland Security said, talked to the CDC folks and said, surveillance is our word. Because they can't use surveillance.
Yeah.
So people started shutting that.
It all depends on who you talk to, right? Yep.
But anyway, so early on in the days, I was in a meeting with DHEC officials, and there was an agent involved in that meeting wanting to know if you could just kind of target certain areas. And I was in the same boat as Devin. I was like, I'm not a public health person, so I don't know. You guys are going to go back to your law enforcement agencies and deal with that. Now, we can generate data. How to use the data from your perspective is one way. But a second note goes back to wastewater treatment plants being seen more as a clinical based system instead of just a wastewater treatment. And I think a large part when all this pandemic work started, surveillance, wastewater surveillance picked up, I think one of the best things that came out of that is a more interaction between state public health labs and wastewater. Before that, wastewater treatment plants were mainly looked at under environmental compliance, right? How much chemicals or whatever are they releasing to the environment? Now we have more of the public health labs that do a lot of the pathogen detection and monitoring, now interacting more routinely. I know when we started, the public health labs here at DHEC had really not even considered wastewater treatment at all. We started out actually working with the environmental side of DHEC for our surveillance, and then over time it shifted to the public health side of DHEC. So it was just an education of the public health lab. So I think we're going to see that continuing to strengthen now.
Definitely.
So,
yeah.
A couple of questions on your phytoestrogen. How recalcitrant are those markers? I mean, are they broken down by microbes?
So interesting that you mentioned. So enterolactone, the chemical that represents lignin consumption, is actually a human gut microbial byproduct of consuming lignans. So that one is, it is a transformative product. Pretty stable, I would say. And I did temperature degradation studies and stability studies basically on all of these chemicals. I should have started there. So they are quite stable. And so I wasn't, if you're thinking about, kind of the different fluctuations there, that was definitely a topic that was considered. And Rolf Halden is also a huge proponent of making sure temperature decay is not something that's happening. So we definitely did our due diligence there. But yeah, very stable chemicals.
So my next question is to follow up on like the geospatial analysis of the nutritionals. So clearly, if you're doing wastewater here, you're going to be focusing more on a connected sewer system. Is that correct? How do you think that would look if you went out to a rural area, say of South Carolina, where maybe people don't have as routine access to, say, processed foods or something? Maybe they have their own gardens and something like that. Do you could you do that type of monitoring? And if so, would you expect to see a difference?
Yeah, I mean, any community, I expect to see differences, right? Definitely rural versus urban. And really just depends on the type of infrastructure that is available in order to collect, that would determine what type of sample that can be collected. And then if you're talking about kind of, targeted versus non-targeted, if we want to just get an assessment of what is available in these two communities, then that would be a non-targeted type of question, right? Because we can't expect really that all communities will have the same type of consumption behavior. But from a targeted perspective, typically, in terms of phytoestrogens, we're all going to be consuming them. So I would just expect a difference maybe in levels of different kinds. Isoflavones, again, represents soy-based foods. And typically, I think what I can attribute most of that initial peak from December to January is from switching straight from meat-based products to soy-based alternatives. And those soy-based alternatives also tend to be quite expensive. So I'm not sure if I would really expect to see that in maybe a lower socioeconomic status area, or maybe in an area where it's a food desert and those types of foods just won't be available. So, yeah, I mean, even just in that quick 2-minute of a response, we're talking about major complexities. And so all of these need to be considered, but, you know, just from a simplicity standpoint, from a more analytical standpoint, if we wanted to just see the difference in what's there in each community, then a non-targeted approach would probably be a better method.
People look at using something like septic pump out trucks.
Yeah.
To monitor those events.
Yep. Mm-hmm. So yeah, just continue to get creative and seeing how we can capture a sample. Yep, absolutely. Laura?
I have 3 questions.
Okay.
So, most recent one was, have you thought about looking at the trucks that collect waste from airplanes to look at the diet? That's at least population that is mostly having known food being given to them.
Yeah.
And sure. But sidebar that. Anyway, the first thing was obviously here you're trying to doing wastewater basically with health. Have you
with health what? Sorry, I didn't catch it.
Health outcomes.
Outcomes, thank you. Yep.
How are you obtaining the health information? Are you getting more buy-in from the clinical side of health, or is this going to be a interactive looking through the literature? Like how do you tend to approach something like that? Because obviously, as Sean said when we first started off, this was what it was there in terms of technology. So what is really that connection of this health and wastewater? Obviously, like you start building trust in the outcomes of it. However, as COVID has progressed, routines have changed again. So there was a focus of sharing that information of SARS-CoV-2 between communities as people have become less interested in SARS-CoV-2 and vaccine. That sharing of information, hospitalizations, or associated health has decreased massively. And so I'm going to have a suggestion of how are you going to make those connections for something that is not being pandemic driven.
Okay. Yes. I'm going to answer your first question first about the airplanes and then talk about, because the second one's longer. So both great ones. So with regards to the airplane and having it be kind of like a isolated signal, like we know generally what they were fed, right? I have been thinking about this from an intervention standpoint, but in airplanes, yeah, that could be a possible avenue. And I know, Aaron Bivens has been doing some work in War Shockman, and I could probably chat with them about what they're doing and how they collected.
The migratory thing.
Yep. Yeah, so like all of that could be super interesting. Yeah, but one thing that I've been thinking about more in this kind of realm is school lunch programs. So very isolated community, right? And I do have, we sampled from a sewage clean out of a school for one project, and the purpose was to include the students that they could utilize the data to invoke policy change. And that would have been a fantastic project had the pandemic not thrown a wrench in that. But we were able to screen just from a few samples that we were able to collect, and we can capture diet, stress, antimicrobials, basically anything that you can in a traditional manhole sample. So from that experience, I've been thinking a lot about, okay, well, what if we implemented an intervention in such, a small community, include the students or, staff personnel, and we know what that change is going to be for that school lunch program, maybe incorporate more green leafy vegetables, and all the while choose biomarkers that would be indicative of that, see if we can actually see a rise in consumption based on those biomarkers, based on that behavior. So same thing could also be applied with airplanes. It wouldn't necessarily be an intervention, but it would be a way to know, okay, what are people eating and how is that translating to the signal that I'm detecting? I hope that answers your question. And then the second point, break it down for me just in like a quick sentence again. Sorry, I lost my train of thought.
The linkage, how you
Oh,
connect the clinical.
yes. Yep. So yeah, there was like a very like arms wide open kind of everyone let's all help and get like share data together during the pandemic, and now things are starting to get a little bit closed off again. My initial thought here, the easy answer here is that it's evolving. I'm figuring out how we're going to connect all of these data sources together. It's going to be linking externally reported sources of what we can, what we're able to get online. There are also certain biomarkers that we can also assess in wastewater that would be indicative of various, say like asthma or diabetes that we can measure in wastewater to also indicate these diseases. All of this I would like to look at in tandem. And then of course, health equity, maybe social vulnerability index and other metrics as well, connecting all of those dots together. So I don't have a clear-cut answer for you, but yeah, it's going to be lots of layers. It's going to be a very dynamic type of approach.
I remember. There is an example in Australia where they have this wastewater surveillance in combination with the police, not to actually arrest.
Yeah.
So the way they got buy-in for it was actually they were using it to increase patrols to act as a deterrent, because there was a lot of people in certain areas who were getting robbed and then not reporting it, but they would end up in hospitals, they would get in taxis and so on and so forth. So actually, they use the wastewater information to increase patrols in areas to act as a visual deterrent for criminals who are looking to make these marks on people.
Yeah, it's a little different than just like going in and making arrests. I think that's the EMC DDA in Australia. Yeah.
Yeah, and I thought that was a really interesting way, because like I also had these conversations about what we need for.
Right.
And there's a lot of interest in it, and ethics of how we use that information, similar to what's happening with the 23andMe and everybody's genomic information belongs to private companies. I think it's an ongoing discussion about what is and is not possible and what we should be doing. But if we can link them, that's going to be really, I think, game changer for
yes to all. I totally agree. It's the ethics, it's an evolving conversation, couple of which we held with Kristen Mansfeld, I don't know, from Colorado. He and I co-led with a couple of others an ethics workshop at AESP, which is the Environmental Engineering Conference earlier this year, and it's just like the conversations are just so fruitful, and it's so great, the level of commitment that people within the field really do have to making sure that we're collecting, ethically sound information, but not only just collecting, it's what's happening after those data management plans, who's actually in control of it. And Sean, you mentioned earlier, we're collecting the data, disseminating it on opioids. What people do with it is not necessarily maybe our responsibility, but I do see in some ways that it is. We have to think about how the potential negative repercussions, could impact certain communities. So yeah, totally. Yeah.
So,
sorry.
You okay? I have two questions. First one's a softball.
Okay.
What position in lacrosse did you play?
I was high attack, so I was the one who was by the other goalie and would be very quick to make the final shot.
As a fellow college lacrosse player, I played
X.
Behind the net.
I don't know. Oh, okay. We didn't have a position X, but okay, yeah. Very cool.
Second question. With your opioid work, did you ever compare those findings and draw correlations with the different catchment areas with the COVID collection, and did you find similarities or perhaps some multiple areas?
So opioid use throughout the pandemic. So at least the opioids that I showed today, we were collecting the data simultaneously, but there were some times where we had to compromise the opioid monitoring in order to prioritize COVID monitoring. So some of those data sets are not exactly apples to apples. And we were not able to see some clear-cut associations there, but there's quite a bit of literature out there now that has monitored an opioid consumption or use throughout the pandemic or the various waves of the pandemic, and they are seeing some clear-cut associations, which was quite interesting. Also, not just opioids, but alcohol consumption and other types of use as well. So yeah, definitely plays it plays the tune to impacts of mental health and what people use to cope, or especially during lockdown periods.
Right, and that's, I think, my leading question is that diabetes, are there metabolites here that are indicative of those disease conditions, and can you do those cross calculations within just the wastewater itself, rather than bringing in health data from the department?
Yeah, that's my goal. I'd say a little bit easier for asthma because we can monitor medications for asthma, which is easier than trying to identify an endogenous biomarker of asthma. So from an individual level, yeah, you maybe not asthma, but diabetes. You can essentially look at hemoglobin A1C. You can look at various oxidative stress biomarkers. So deoxyguanosine is one, which is excreted in urine. And so we could look at that in wastewater, and I've been able to detect that. But we do come down to the specificity issue, because increased oxidative stress, yes, is very prevalent in diabetes patients, but also is prevalent in other conditions as well. So I want to come up with these basically biomarker suites where all of them essentially complement one another, but then also maybe bringing in those external data sources as well, probably more for like validation purposes, or just to compare like how we would with SARS-CoV-2 in case rates. Yeah. I saw two other hands, I think. Yeah.
We need to make a DHEC connection with chronic disease.
Absolutely.
Acute disease involved, but chronic disease surveillance spends millions of dollars on BRSS, RBS, and EPS, and IPS. You can save them hundreds of thousands of dollars.
Oh, I bet it could. Yep. Yeah, definitely. Awesome.
On what Dr. Kilpatrick has just said, I mean, did you also see an association? And I know you saw that temporal association with a plant-based diet, but was there also an association like with the communities that were more likely to have the high rates of COVID-19 and plus substance abuse were less likely to have
the plant-based diet behavior?
Yes, because I mean, socioeconomic status.
That would have been a fantastic study. I didn't look at all those data sets in tandem. That would have been great to see.
So to bring this to a close, I want to plant a seed to you, because we reference nutrition within our schools, our school districts, recognizing that schools play a significant role in the provision of nutrition for so many families. One of the big controversies taking place right now at our General Assembly is involving discussions or concerns about disparities in the quality of nutrition that's available across school districts in South Carolina. And a gentleman that Katia and Daniel and I work with, Representative Jermaine Johnson, is leading the discussion about removing the food nutrition program from our Department of Education and moving it to our Department of Agriculture.
Okay.
To help to address. So there may very well be an opportunity to engage with our folks to do the type of study that you're talking about.
Yeah, I would love to be connected with those folks. Yeah.
And we would love to, introduce you to our representative who's
I would really appreciate that. Yeah, that sounds amazing. Great.
Okay. Well, I think that also puts it 2015.
Thank you so much for all your questions.
Very, very much.
Thank you. I know I talked about, sorry.
Laura, you're next week, correct?
I know I talked about healthy eating and nutrition, but I did bring in candy in celebration of Halloween coming up. So please feel free to take some on your way out. And you can leave the note cards where they are.